Hello, my name is Ryan Stromitis. I'm a medical toxicologist and addiction medicine physician at Lehigh Valley Health Network, a part of the Jefferson Health Network. Welcome to this PCSS mini video on managing medications for alcohol use disorder, or MAUD, in the surgical setting. Managing and planning surgery for patients on MAUD presents some unique challenges, especially when it comes to balancing adequate pain control with the need to safely continue or adjust their treatment plan. We'll provide a practical decision tree to help clinicians navigate through every stage of surgery, from preoperative planning to postoperative recovery. Effective management begins before the patient enters the operating room. The first step is to determine if the patient is currently taking or has taken any MAUD medications within the past 30 days. When collecting this medication history, keep in mind that some patients may not voluntarily report their MAUD, or they may simply forget to mention it, especially if they're receiving monthly injections that are not part of a daily routine. It is vital to establish the exact date and time of the patient's last dose. When we are talking about MAUD, we are specifically looking at three medications: naltrexone, acamprosate, and disulfiram. The implications for surgery vary significantly depending on the medication the patient is taking. Acamprosate has no opioid interactions and is generally safe to continue both before and after surgery. Disulfiram has rare anesthetic interactions. However, the recommendation is for patients to stop taking it at least 24 hours preoperatively. Naltrexone carries the most significant implications because it blocks opioid analgesia. If a patient is on naltrexone, we must use a specific decision tree to guide our next steps based on whether the surgery is elective or urgent. For elective surgery in a patient on naltrexone, the timing depends on the formulation. If the patient is on oral naltrexone, it should be held 48 to 72 hours before the procedure. If they are on the monthly injection, elective surgery should be delayed until 3 to 4 weeks after their last injection to allow the blockade to wear off. In cases of urgent surgery, we must prioritize multimodal non-opioid analgesia using tools like ketamine, gabapentin, or IV lidocaine, and consider regional or local anesthesia such as nerve blocks or epidurals. If opioids are absolutely required while naltrexone is still active, the patient will likely require higher doses to overcome the blockade and will likely need high-level or ICU monitoring due to the risk of delayed respiratory depression as the naltrexone wears off. Moving to postoperative care, both acamprosate and disulfiram can typically be resumed following surgery if they were held beforehand. Naltrexone requires more caution. It should only be restarted when opioids are no longer required and the patient has been opioid-free for 7 to 10 days to avoid any precipitated opioid withdrawal. If a patient was on moderate to high doses of opioids post-surgery, a test dose of 12.5 or 25 milligrams of oral naltrexone is recommended before resuming the full dose. As we wrap up, remember that postoperative period is a delicate balance. In this phase, we have to carefully weigh the use of full opioid agonists for pain control against the priority of protecting the patient's long-term recovery from alcohol use. For those still drinking, promote alcohol cessation 48 to 72 hours prior to surgery and monitor closely for alcohol withdrawal syndrome. Once the surgery is over, taking a moment to review their actual opioid needs, as the goal is to use the lowest amount necessary. Finally, consider a warm handoff by personally connecting the patient back to the clinicians managing their AUD. This direct handoff is a vital step in supporting their long-term recovery, particularly for patients who may be newly diagnosed. Effective perioperative management of MAUD ensures that we provide safe, compassionate care without compromising the patient's recovery. Thank you.